Anxiety is a gateway disorder. A gateway disorder means, and this comes from Ron Kessler, who's one of the leading epidemiologists in the United States. A gateway disorder means that it's usually the first disorder after which you're prone to other more problematic disorders such as depression and substance use. Just like there's gateway drugs that kind of introduce, youth to more mild drugs, only to leave them more prone to more severe drugs, anxiety is very much like that in terms of being a gateway disorder. Stress typically is experienced in stressful situations, right? It tends to minimally interfere. Like we can all usually function with stress. It's easy to control. Thoughts and fears tend to be realistic. They're not outlandish or out of line with the demands of the situation. And when others reassure us when we're stressed, that tends to be helpful, right? Reassurance is a normal, especially for children, a normal approach that's very helpful. If we're talking about anxiety, remember an anxiety disorder has those, the psychiatric disorders have those two components, severity and impairment. So let's expect with anxiety, the severity is going to be worse and there's going to be impairment. So therefore, feelings are worse, right? The feelings of anxiety and the manifestation of the disorder itself may come and go, but over time, it's chronic and it leads towards greater severity. So it might wax and wane. Children with OCD frequently will say things like, I had like an OCD episode when I was 7, but then it went away. And then I had one when I was 14, and then it went away, right? So it might wax and wane, but then each time it comes back, if it's not treated, it comes back at a higher severity. Anxiety it interferes with activities, so we have impairment. So there's emotional symptoms, thoughts, and behavior, which forms a spin cycle if we engage in those rituals. I'm going to walk you through how to treat that. So the first line treatment of OCD and the anxiety disorders is a specific form of cognitive behavioral treatment called exposure with response prevention. So cognitive behavioral treatment is a large umbrella term under which there's specific CBT, cognitive behavioral treatments, for different disorders. There's a particular cognitive behavioral treatment for tic disorder and Tourette's, for depression, and for anxiety. The treatment for anxiety is called exposure with response prevention. The goal is to lower anxiety, build tolerance of our fears, and heal emotional injury, right, out of which we suffer. In order to most effectively implement exposure with response prevention, it's important to attempt to identify the core fear. The questions that I gave you before will help you do that, right? Like if you were to bring on anxiety, tell me what you would do. That's an important question because for somebody who avoids, they aren't going to be encountering their anxiety triggers, right? So if we're looking for trouble, tell me what you would do and walk me through what your experience would be if you did not engage in these compulsions. That will give you an understanding of the core fear. If you don't know what it is at the outset, if we're spending all our time running from something, right, the anxious person is kind of avoiding their feared consequences, they have limited insight into what it is. So if we don't know, that's okay. Like treatment builds insight as we move through it. So core fears are distinct from situation-specific circumstances. I gave the example of tapping, like, that felt wrong, so I have to do it on this side. That's a situation-specific obsession and compulsion. The core fear examples include things that really persist across time, like loss of control, or what if I feel this way forever, or rejection, abandonment, shame. Gradually practicing exposures puts the acceptance that I talked about at the beginning of this segment into action. So exposures are exercises that improve tolerance of triggers of anxiety, especially the core fear. There are 3 types of exposure. There's in vivo exposure, and that is a fancy word for, like, in life, we're engaging in an action. So if I'm afraid of dogs, I would bring a dog in the room. That's an in vivo exposure. By the way, I start with a puppy because we don't want to traumatize the poor kid, right? Imaginal exposure is confronting, and this is a very important one because most of our anxiety is in our thoughts long before it's in our behavior. Imaginal exposure confronts individual fears and overall feared consequences in thought, right, in our imagination. For panic disorder with agoraphobia, interoceptive exposures are used. I don't know if you've all heard that. It refers to the specific exposures that are used for panic disorder. With panic disorder, with somebody who's afraid of a dog, the dog is the trigger. With panic disorder, my feelings are the trigger, right? Like if I start to feel anxious or my blood pressure increases, and I might not even be aware of those changes, like I'm sweating more, those triggers induce greater and greater and greater anxiety. So therefore, the exposures need to be to those triggers. So examples include feared sensations such as a pounding heart or dizziness. Reverberations of anxiety, this is one of a very important point from today's presentation, are invariably observed across settings. The more severe the anxiety disorder is, the more the reverberations are going to be observed among the parents, the siblings, the school, the treatment provider. Because there's treatment resistance, therefore, treatment needs to focus on all of these settings in order to be effective. And we actually get the best prognosis if we focus treatment on these multiple settings. If we look more closely at environmental factors that maintain the anxiety disorder and family patterns associated with treatment resistance, no two sets of parents are perfectly unified. And by the way, all families are different. We treat families in different shapes and forms. I'm going to use the example of a two-parent family just to kind of simplify and start with that foundational understanding. But we frequently work with children where the caretakers essentially are mother, grandmother, stepdad, right? And so there are applications in those settings. No two caretakers or parents are perfectly unified. In the presence of an anxiety disorder, and especially when it's more severe, the parenting becomes less and less unified. So there's a division that the anxiety disorder creates in the parenting. A very common pattern, right? This doesn't apply in all circumstances, but what I wrote here is what we see frequently, time and time again, is that one parent is more all or nothing, and sometimes the bad parent, and sometimes with OCD contaminated. The other parent may be overly accommodating and sometimes is pushed around or abused by the child. That parent tends to feel overwhelmed, like they're handling it. One parent has no credibility, usually, right? And it can vary. It could either be the accommodating parent that holds back the bad parent, right? So sometimes that highly accommodating parent, I had a discussion last night actually with a client where the accommodating parent was the mother who was very worried that if a limit was set with her daughter, that she might not have the resiliency to handle the limit and might feel an excessive amount of shame, right? So that she would hold back, and correct her husband from delivering correction to her daughter. So there's an example of the accommodating parent holds back the parent that is viewed as the bad parent by the child. The all or nothing parent may make all the rules and the accommodating parent has no credibility. That's the other way in which this presents, where the all or nothing parent tends to be more involved. In a case example we're going to look at later, you'll see an example of that, where that parent has more of the credibility than the other. In terms of school patterns associated with treatment resistance, and remember, with treatment resistance, there's reverberations across settings. Just like parents with children with treatment-resistant anxiety disorder are pulled to extremes of over and under accommodating, there's also over and under accommodation at school. So schools can be either not accommodating enough, like for instance, just do it, right? Or overly accommodating, whatever you need. Like anytime you want to go to the nurse's office or come in late, whatever you need, that would be an example of overly accommodating. The other circumstance we see in schools, which is unhelpful or less helpful, are the use of boilerplate accommodations that aren't designed to meet the individual needs of the child. And that is probably because of a difficulty kind of conceptualizing the disorder and coming up with treatment goals that are relevant. The school is an important setting. It usually needs to be included in treatment, especially if we're talking about these at-risk children. The school needs to be included. If we're talking about mild to moderate, it might be optional. Some parents don't want to include the school. They might have some misperceptions about if I include the school, then the child will be judged negatively. Conceptualize all that, by the way. Whatever the beliefs are about including the school, that is probably part of the clinical picture. Expect to see the child's dysfunctional coping strategies present in the school setting. There's either great dysfunction at school, or as I mentioned before, the child looks perfect at school. And in some cases, unfortunately, the schools, in our experience, have been, this is rare, but reluctant to accommodate because they might state something like, we don't see any problems in school, and accommodations are meant to address problems with academic function, because there's no academic, functioning impairment we're not going to accommodate. Now, meanwhile, this child that I'm thinking about was up to 2 in the morning doing homework, and all weekend had OCD and couldn't get accommodations in school. Treatment needs to include a behavior plan implemented at school and exposures that are performed at school along with flexible accommodations. So the treatment plan that we worked on before can include school goals, like I think someone mentioned, if the child goes to the nurse's office, and then I suggested a treatment exercise, and the child goes back to class. The majority of individuals with mental health problems do not receive evidence-based practices. And this is from the U.S. Department of Health and Human Services, and among others. 12 states mandate the use of evidence-based practices in their mental health system. Those that receive treatment that's not evidence-based receive poor quality treatment. 90% of state mental health authorities in the U.S. report strategies to implement evidence-based practices. Dissemination efforts have resulted in low rates of uptake. I mentioned the person with OCD, on average, takes 17 years to find effective treatment. There's a low rate of uptake. Approximately 14% use evidence-based practices after 17 years of dissemination efforts.